Sufyan, we can give the countdown and we can go on live. Ma'am, I think we are already live, ma'am. I think we can.
We welcome everyone to this yet another Surginar, and this is nothing but the deferred live surgery and surgical demonstration of the live cases which have been done before. And the interesting live surgeries are going to be on new freeform diffractive intraocular lens technology. I have with me the chairman of this Surgenar, Dr. N.V. Arulmozhi Varman, Medical Director, Uma Eye Clinic, Chennai, and he's also going to be doing a surgery. And Dr. Gaurav Luthra, who's co-moderator with me, Director and Head Drishti Eye Institute, Dehradun. Apart from this, we would have the first deferred life surgery from Dr. Partha Vishwas, immediate past president of All India Ophthalmological Society and medical director for Trinetralaya, Kolkata. The second one is going to be done by Dr. Arulmozhi Burman from Uma Eye Clinic, and we would conclude with the surgery from our youngest surgeon today, and that is Dr. Aditya Burman, again director Uma Eye Clinic, Chennai. We have our panelists to discuss Dr. Suresh Pandey, Director Subi Eye Institute and LASIK Laser Center, Kota, and Dr. A.K. Tandon, Director Tandon Eye Hospital from Mumbai. So without standing in between the live surgeries and our delegates who are watching, I would request Dr. Partha Vishwas to show his case.
has to cooperate to the instructions that we are going to give the patient, and the docking is actually a very smooth one. It doesn't hurt the eye, and once the LOI is in place, then we place the patient's head just underneath the cone, and the docking takes place quite seamlessly. And then our focus of attention goes to the system in which we are seeing the docking and the screen where we have the docking in place and we see all the parameters that are there. So once the screen is in place, then it's important that we finalize the docking, and there's an internal guiding system in which we get a very good OCT view of all the layers right up to the lens. And once this is done, then we can actually check on the pupillary size and also manipulate manually if there is something that we need to adjust to. But this is not very important in this particular case, but in other cases, this becomes quite important. So once the docking is done, then of course we go on to have the patient and confirm the docking, see the pupillary size, see the rhexis, see the incision, and once the incision is well attuned, then we go on to fire the laser. So it takes just about 1.4 seconds for the capsulotomy to complete, and then the incision, the main incision is done. And here, of course, for the lady, we did the arcuate incisions also. So that is done. The patient is shifted out, and with the patient getting shifted out, we get in, we wheel the patient into the surgical theater. Now, in the surgical theater, of course, everything is exactly how it is, and we start off the surgery adjusting the microscope, telling the patient, and the patient, of course, is under topical anesthesia. So the patient's cooperation for topical anesthesia is always something that is important. Here you can see a few subconjunctival hemorrhages, but these usually disappear in day 1 or day 2. And if it disappears, then of course we are quite fine with the patient. Now, the side port incisions we have not made, and the side port is what we are making now. And with the side port incisions in place, we open up the incisions. The first thing that we place is methyl cellulose over the cornea for the clarity, and we eye as well, phenocane. And the viscoelastic that goes in, first a blob of the viscoat, and then we place in methyl cellulose to top it up. So both the chondroitin sulfate as well as the methyl cellulose works well to protect the corneal endothelium. And once that is done, so you can see the arcuate lines in place here. You can have a look at the free-floating capsulorhexis, a few tags here and there of the capsulorhexis, and you can see the dimensions of the incisions that have been made in the cataractus nucleus. So the rotation is something that is quite important after doing a hydrodissection. And once the hydrodissection is done, the rotation and removal of the nucleus is something quite fast, and especially with this machine. We are using the Veritas machine, and the machine has an excellent fallibility. And the amount of control that we have with this particular Veritas machine is really very good. So you can see the steady chamber as well as the removal of the nucleus, which have been made into 4 quadrants. The removal of the nucleus is not difficult. Again, this is a grade 2 nucleus, and it separates quite well. So if required, we always top it up with viscoelastic methyl cellulose or with chondroitin sulfate. and the removal is quite seamless. It's important to understand at this point of time that the amount of energy that we use for removal of the nucleus is really very, very low. And it also gives an advantage even in a soft cataract, the catalyst. So it divides into 4 quadrants, and it's quite easy to take off the 4 quadrants very, very well. And at times in a soft cataract while doing phaco, it becomes a little difficult, and you can see that the pieces are coming off very fast. And there is no ball created, which at times in the soft cataract might be created, and that has to be taken care of. And the nucleus disassembly becomes a little more difficult than a routine cataract at times in a soft cataract. So once the removal of the nucleus fragments are taking place, then we remove the cortex, which again is something very smooth, and removal of the cortex takes very little time. There is just a little bit of difference between removal of the cortex, between the phacoemulsification, irrigation aspiration mode, and the femtolaser system irrigation aspiration. Because what happens is we have actually gone a little deeper by millimeters into the cortex as well. And the cortex is a little sticky at the edges of the anterior capsulotomy. The other thing that we always have apprehensions whether the capsulotomy is as strong as a manual capsulotomy. Well, we hardly have ever a capsular run out after a good capsulotomy has been made by the femtosecond laser. And the capsulotomy is really quite sound. It's only if either one of the instruments brush or impact on the capsulotomy edge that there might be a tear and there might be a possible the movement of the haptics and the optics within the anterior chamber is very, very smooth. So we just gently place it in. And here, of course, it is a non-toric intraocular lens. And because the 0.95 was taken care of by the arcuate incisions. So the removal of the excess viscoelastic is next done. And you can see the number of rings. Now, just going to the number of rings that we had seen in the Synergy intraocular lens, and it was 15 in number. Even in this, it is 15 in number, but of course, the eclet design of this particular lens is much different from the eclet design of the Synergy. And the mounts are much lower, and thereby the amount of halos and glare in patients is much less. In fact, the patients that I've placed an Odyssey in, so these patients have not complained as of now of any night vision difficulties, glare or halos. And the patient next day has been extremely happy, and we've had this patient now for about 1 week now. And as you can see, it's extremely well centered, the lens, and you can see the Purkinje images there. So very well centered. And this particular lens is also supposed to take care of any residual refractive error that might happen. And if it happens, even then, the patient usually reads 6, 6, and 6. And you can see that the centration and the designing of the lens is very good. With this, we close the surgery, and
So, thank you so much, Dr. Partha, for that excellent demonstration of a textbook-like case. No, we can't see the picture. So Gaurav, over to you for the discussion.
Yeah. So, Gaurav, that is exactly why I showed this particular case, because, this was a high myope. So we are always apprehensive for doing a trifocal, either on a high myope or a high hyperope. And because of the chances of and the possibility of refractive residual error. However, in this one, patient audio break हो रहा है. अच्छा. Is it okay now? Is it okay? Mrs. Sufyan, is it okay? Okay, okay. So the high hyperopes and the high myopes are always a little bit of a challenge, but in the ones that we have done for so far, the high hyperopes and the myopes are a little more. High hyperopes maybe just a couple of them, but the post-operative vision has been very, very good and very well done. So, and I used the Barrett formula for this patient also, and it was pretty good. So even with high myopes, where you can expect a little bit of residual error, but this did not have so. So
let's take the opinion of Dr. Suresh and Dr. Ayush on this. Hi, Dr. Suresh. Hi, Dr. Ayush. No, we can't hear you. Dr. Suresh, unmute yourself. Sorry.
Hello. Very good evening, Dr. Gaurav. Can you hear me?
Yes.
Yeah. Dr. Partha, excellent surgery. Very nice surgery you have shown. My question is that you have beautifully shown the implantation of toric lens in a myope case. Do you think that, implanting the CTR ring may be helpful to provide the long-term stability? Maybe, now we have the hydrophobic lenses with the techie surface. The haptics are also, designed in such a way to minimize the rotation. But there are some studies in the past where they suggested to implant the CTR in toric cases to minimize the post-op rotation. So what do you think about that aspect?
yeah. Yeah, thanks, Suresh, for taking this up. And in this particular case, it was a non-toric because
Yeah.
it was just a 0.95 of
Okay.
astigmatism which connected by the arcuate. But nevertheless, this
Yes.
is an important question.
Yes.
And even if we had to do a toric in this particular patient, see, even my thought on the torics and high myope, in which the bag is definitely assumed to be larger in size, I usually do not put a CTR unless we see that there is a little bit of zonular dialysis or subluxation. Then only we go in for the devices. And the lenses have really stood the test of time, and even the Technis platform, the toric platform of the Technis or the other platforms, and even with the Odyssey, I think the stability is very good. So I usually do not put a CTR for a high myope patient unless there is a zonular dialysis.
And I have a quick
Hydrophobic
question
material is very good.
Yes,
Yeah,
it
it's
is.
sticky
The
surface
stability is
and
very
frosted.
good. I have a quick question for Dr. Ayush, and I thought, Dr. Ayush, would you be happy to share your experience between unilateral and bilateral implants with your DC? Like, do you promise your patients, like, do you typically tell your patients that both eyes are going to be done close to each other? And how is the difference after the first eye? Do they do much better after the second eye? So, what's your usual plan?
Can you hear me?
Yeah, yeah.
Yeah. So see, I always check the dominant and the non-dominant because I have done some bilateral implantations of Odyssey, and I have experienced some patients complaining of not getting crisp near vision, like N6, especially when they're newspaper readers. So I always check the dominant and the non-dominant. Plan the first eye emmetrope non-dominant eye, and the non-dominant eye still take first myope, and that has given me an excellent result as compared to crispness of synergy for the N6. Yeah.
Because the J&J obviously is telling that for Odyssey we should be using the first minus anyway, as compared to Synergy and all the other multifocals, because Odyssey works better and it has a great tolerance for refractive errors also. It can tolerate almost half a diopter of sphere and cylinder, and patients they don't lose uncorrected visual acuity. I typically go for a small myopic one for both eyes, and it works well. And yes, if first eye patient for some reason is complaining that he's not enjoying his
Yes.
near vision, the second eye can be made slightly more myopic. But typically, when you do both, they typically, even with that 0.25 of minus myopia, they start getting excellent near vision. Apartha, would you like to chip in, and then we can go on to the next surgery?
Yeah. So here, remember, Gaurav, we were discussing about the Odyssey, and you had shown one of your cases in which after a refractive surgery,
Yes.
you had put in an Odyssey, and I threatened you that I'll put you on court martial if you do that. So,
Yes.
but no, but I think, the Odyssey, and especially the benefit that your patient had, so that is something that's really good. However, I think initially, if we are starting with the Odyssey, maybe we should avoid the ones with maybe a corneal haze or a corneal opacity, or a scarring where you have astigmatism, which is not very good. And so these patients might have a little bit of deficit of the postoperative vision and the postoperative visual acuity, as well as the contrast. So best to avoid these, especially because these are lenses of very high order, and we can always tell patients. However, in very selected cases, we can definitely do, even with a corneal opacity, somebody who's very elderly, not able to find glasses, things like that. So, one has to choose this lens according to the patient's profile as well.
Perfect. I think we are a little behind schedule. We'll probably move on to the next surgery, and I think Dr. Arun Moy is planning to show his case. Dr. Namrata, would you like to invite sir? Or otherwise, if sir is ready.
I'm ready.
All right, sir, let's go ahead, sir.
Sir.
We'll hear you. We are
Sure
looking
thing.
forward to see your surgery. And
Can I share my video?
please go ahead, sir.
Yes, sir.
Yeah. Good evening. Yeah. Here we are. We're going to start the surgery here. So this, I'm doing the surgery with the Veritas machine and with the Zeiss 3D RTO. So patient's already draped. Patient is a 63-year-old lady with a fairly dense PSC. The K1, K2 are pretty much close to each other, almost spherical. So there's no, we always do the Barrett 2 universal with the toric calculation to see if the patient needs a toric. This patient did not need one. So my standard operating procedure would be a topical anesthesia and a proper draping of the lids. And we always put in a little bit. We already washed the eye with betadine, but as I start, I just put in a couple of drops in both in the fornices, wash it off. And we always do a marking where I'll be able to get almost a perfect incision every time. So to do the marking of the cornea, before we start the marking, I just dry out the cornea a little at that point. And this is a marker that I've designed, which gives you a mark about 1.5 millimeters. So one mark goes on the limbus, other is 1 millimeter into the 1.5 millimeters into the cornea, so that you can now dip in exactly at that point and get 1.5 to 1.75 millimeter long incision every time. So once that is done, we put an intracameral anesthetic. That's a 1% lignocaine, preservative free. I'm very particular about the side port incisions, which are small. You'll find that the knife goes in only half, not fully. So I want to maintain as watertight as possible with no leak at all, so that the chamber stability is good. And this helps particularly in IFIS. When you have the floppy iris syndrome, you can safely do the surgery as long as you do not have any leak out through the side ports or to the main port. That's critical. I always do a soft shell technique. This is sodium hyaluronate with chondroitin going in first. So under that, I put in HPMC, which is my standard practice for all surgeries. You notice here it's a fairly dense PSC. The nucleus is probably grade 2. So I always like to use the needle for rexus and the rod in the left for stabilizing. And I always like to start almost downwards and make a small C so that you can lift the flap up. And the first movement would be to turn the flap over and flatten it so that it doesn't float around. That gives you exquisite control. And you take it around like walking a dog on a leash. It's very critical at this point that the flap remains flat and not bunched up. If it bunches up, then you lose orientation. As long as it's flattened, your orientation is perfect. So once you've got a decent rexus, please decompress and shallow the chamber. Go just under the rexus margin, lift it up off from the cortex and inject one bolus and decompress. You've got a good, where you've done a true cortical cleaving hydrodissection. So towards the end of surgery, the amount of cortex left over would be minuscule or sometimes nil. I normally do a direct chop. Incision size here is 2.4. And this phaco tip is a personal design of mine, which is a pentagon shape design with asymmetry in the weight in the upper and the lower ends, which causes a better emulsification. First step I do is to clear the cortex and the epinucleus in the rexus area. And you'll notice this chopper also has got a side cut. You'll see how it cuts in. So you enter in, go deep in, hold, and separate. So that the chopper cuts side cutting. You notice that it's sharp on the side. So your chops are instantaneous, less stress on the zonules, and more ergonomic also. I'll always encourage anybody to keep chopping into smaller pieces. Don't be satisfied with big pieces. Make them as small as possible so it's more efficient. You'll find the efficiency of this phaco tip as well as, of course, the Veritas machine very high. And on the RTO, you can go into really high magnification if you want to demonstrate something. Enter in, hold, chop, separate, and pull. And you'll find that all the work is being done by the chopper and minimal movement on the phaco probe. The phaco probe stays right in the center, almost in the bag all the time, except for the last piece, you probably come out just at the level of the iris. Always try to occlude, pull back, and then apply phaco energy. Don't go hammer and tongs. Now, if you've done a good cortical cleaving hydrodissection, this is the kind of result you will end up with almost no cortex left over, literally making your work simpler. And I'd like you to notice all through what at the side ports, they don't leak at all. So that really gives you a totally different dimension of stability. The cortex remaining is very minimal in the periphery. All you need is already loosened. You go pull out as much as you want. You want to polish the posterior capsule, go ahead. Because most of these so-called premium lenses, you want as clear a posterior capsule as possible, because even slight amounts of posterior capsular issues can interfere with clarity as well as the multifocality. And I can tell you to look at the side ports. No leak at all in the very minuscule on the chopper side. Otherwise, that's the main thing I wanted to notice. Now, for all implantation, we go in for sodium hyaluronate, which comes out quicker, faster, and causes a lesser postoperative intraocular pressure rise. The Odyssey lens comes preloaded. That part of it didn't get recorded. It's been readied by my OT staff. So then get it ready, bring it down to the nozzle. This was a plus 21 diopter lens. Of course, it goes through 2.4 very easily. 2.2 itself, which will be injectable. The J&J material unfolds very slowly so that you have enough time to manipulate the lens into place with no difficulty whatsoever. In the center as well. Of course, you can see the rings on the Odyssey. They are a little less distinct than the rings on Synergy. What is the advantage we get here? It's difficult to say. I've been using it for a little over 6 months, a fair number of lenses. They're very good. You do get clear vision over all distances. Most of my implants are bilateral, so I do it within a gap of 1-2 days. And we do find that it does give you N6 when I implanted bilaterally, comfortable with low amounts of dysphotopsia. That's the main advantage that you get in the Odyssey. Dysphotopsia is much lesser. So we end up with just minimal hydration and intracameral antibiotic, and that's the end of surgery. You would find that I did not have to hydrate the side ports at all because they were actually designed very small with absolutely no leak. You don't have to hydrate them at all.
That's a beautifully done surgery, sir. And all that, in fact, I learned so many new things from your surgery. Especially the fact that you mark that incision. That's something very nice. Whoever wants to learn from you about how to get the correct sized incision and the correct, the length and the breadth of the incision. So I think I'll let Dr. Namrata, lead the.
No, it is perfectly all right, Gaurav. You're doing a great job. I just wanted to know one thing. Nowadays, there's a new trend of doing mix and match. They put EDOF in one eye and multifocal or trifocal in the other eye. So, sir, have you tried ODC in one and Eyehance in the other, or
No,
likewise?
never. I almost never ever do that. I used to do a mix and match earlier with the Technis, the bifocals that they had. They had 3 ads, 2.75, 3.25, and 4. So I would put in 4 in one eye and 2.75 in the other eye. So this would give almost the same kind of effect that a trifocal would give. But now I really find logistically, when I ask them to supply a specific ad, it's kind of difficult to get it from J&J. I've stopped that part of mix and match. The other mix and matches I've done is Eyehance in one eye and Pure C in the other, which is kind of good, but I would rather go, if I want EDOF, I'll rather stay with Pure C. So as of today, in my practice, monofocal means Eyehance. There is no monofocal per se. It means Eyehance. That's what we call we don't tell the patient anything about it. We just charge them for that. And we put an Eyehance as a monofocal. That's a standard practice. And those who want EDOF and lean towards Pure C, where I'm quite happy with the results. Again, as Partha said, Pure C, you may not get great results in a myope. You have to be a little careful in those patients. The near vision may be not so good. And about 20% of patients, even with those with good results, would need a +1 to read in dull light, very small print. So these are things that are one that takes, you have to tell the Pure C patient. So the advantage now that you have Pure C and then you have Odyssey and Synergy or whatever, is it saves you a lot of counseling issues. Now you can tell the patient, you want absolutely good near vision, here I have this lens, but don't ask me if you get glare and halos. You don't want any glare and halos, here I have this lens for you, don't come and ask me if you can't read very small print. So patient is forewarned and then all your headaches are gone. So that's what I do, and I'm sorry, I don't really do any mix and match of ringed lenses and non-ringed lenses yet.
So I think you've given us a very good mantra for counseling. that if you
Yeah.
want near, don't ask me for halos, and if you want halos, don't ask me for near. So it is like that. But I think that is there, and that means monofocals are completely out. Tectus is completely out, almost out from your practice.
Completely. Actually, I don't have any techniques in my practice anymore. Monofocals.
So, Namrata, can I share my
Yeah.
little experience? Yeah. So, about the mix and match, sir, Dr. Arulmozhi Varman, we definitely have some patients who have had a need off and not very happy with the near vision, and then they ask that why am I not getting near vision? So there are a couple of patients in whom we had it off, and the next one we told them that it might not totally match, but you will have the benefit of a near vision if we put in a trifocal. And in such patients, we did put in a trifocal, telling them that there would be a difference between the right and the left eye, and but you will be able to see your near vision. So such patients with good counseling, I think, can be one of these that we can put in a mix and match.
Yeah, definitely.
But however, I will 100% agree with you. With the ODC, the continuous range of vision is excellent. It is excellent. And the glare and halos, patients have really not complained of, which is something very important. And that's how it transforms from the designing of this particular lens vis-a-vis the Symphony, which had the glare and halo aspects, and some patients we did have difficulties, but with the Odyssey, the experience is very good.
What about Synergy? In between, Synergy was also there. So what do you think? And I know that Synergy is going to be discontinued because in the West it was already discontinued.
Must be discontinued because with the Odyssey coming in, I don't think any of us would like to put in the Synergy at all.
I don't think it's a question of we liking it or not. The company is not going to have such a large range and manufacturing and logistics and cost involved. They will discontinue one of the two.
Yes.
But today, sir, if you had both options available, will there be a patient where you would want to use a Synergy instead of the Odyssey, or would you just go with the Odyssey and you've stopped using Synergy?
If somebody were to be very insistent on near vision being really good and they don't mind a little bit of glare and halos, I would still go with Synergy.
True.
That's
what
absolutely true.
That's what I.
Absolutely true. I still use Synergy even now. I'll keep using it until it's available.
Dr. Gaurav, can I ask one question?
Sure.
Yeah, Dr. Varman, excellent surgery. I have keep on seeing your surgery since I was a resident, and I think you have trained more than 100 ophthalmologists, or you have seen the era of ophthalmology evolving from ICC to ECC, and then phaco, and then finally femto. So thank you so much for teaching and inspiring the generations of ophthalmologists. My question is that you have beautifully shown the surgery and lens implantation. If I ask you which lens you prefer for your own eyes, so what will be your choice, sir?
Good. If and when I get it done, I've already had a presbyon done. So
Yes.
I'm not a candidate for any of these lenses that are multifocal. So it would have to be maybe some you would eat off, but then we'll have to look at my corneal aberrations at that point, and then choose a monofocal lens or maybe a eat off, which has aberrations that will not go counter with my corneal aberrations. So eventually I'll end up using a monofocal. But if I did not get, I have not ever had a presbyon done, I'll probably go with Priosi as of today's technology because no glare and halos at all. And I would not mind wearing a +1 for very fine work, but bright light, hold it 3 inches away and you're good to go. So not an issue. I'll be happy with that. So that will be my answer as of today.
Okay, not related to this, but I just want to know, did Presbyon help you and for how many years?
It's about 1.5 years now.
Okay.
So absolutely glass free and I'm quite comfortable. I have no issues whatsoever. I drive everything, drive at night. I'm operating. Actually, I got my presbyon done at 5 p.m. on a Monday, and then Tuesday morning came to the OP. Aditya removed the BCL, and I walked into OT and I did 3D surgeries, 8 surgeries that day, straight off the bat.
Okay.
All right. So, Dr. Ayush, you would want to give any comment?
I think all points are covered, but I just wanted to ask you that, like, when we can you hear me?
Yeah.
So specifically, sir, like when people come and they say that they do have a night drive, say around every day, 45 minutes to 1 hour at around 8:39 while coming back. So would you still choose Odyssey, seeing the glare halo profile? Because at the end, it has rings, right? So would you choose Odyssey still?
Good. I'll give you the answer. Now, my question to that particular patient, because most of your cataract patients are 60, 65 plus. Of course, you have younger patients. Let's now take a typical patient, 60 or 65 plus. My question to that person would be, your night driving is city or do you drive on a highway at night?
Okay.
If they say they do not habitually drive, and I tell them, if you're going to go for these lenses, please do not drive on highway at night at all. If you're going to be
Okay.
that way, then in the city, trust me, whether it's Synergy or it is Sodesi, the glare and heroes are quite bearable. They do not give you any kind of safety hazards. They're a bit of a nuisance, but they don't give you any safety hazards at all. So no issues. You can very comfortably put in these lenses and people who are going to drive at night in the city traffic.
Okay. Thanks.
Okay, I think with this we'll move to the last case that we have from Dr. Aditya Burman, and over to you.
Yeah. Good evening, everyone. So thanks, my best regards to AIOS and J&J for giving this opportunity to present here. So I'll just start to share my screen. So this is the live surgery that we had recorded the previous days before. So this is a patient who's fairly young. This patient was in the mid-50s. She now has an early cataract around NS1 grade or so. So we have planned to use the pure C lens here for this patient. This case is being done under topical anesthesia. So we're just getting set up here. So just like it was previously described in the previous surgery, I also follow the same standard operating procedures as my father as well. So I start off by making the same incision mark. We make it temporarily. This patient is a little bit anxious, so but sometimes you have to expect this when you're doing topical phaco. So we make the mark and then we make the small groove at the limbus. So this mark making is very useful because you end up with a nice 1.25 to 1.5 square shaped incision every time. You just have to enter and dip down at the mark that is made in the mid peripheral cornea, and then you have to just enter all the way in. And you get a nice, very square shaped incision. You know, inserting our 1% lignocaine here for topical anesthesia. I also like to follow the same soft shell technique where we place visco with sodium hyaluronate and chondroitin first, and below this we place HPMC. The HPMC is placed because this helps us in doing the rexes very easily. Whereas if you try to do the rexes with sodium hyaluronate and chondroitin together, it might get a little sticky and it will not be so comfortable to do the rexes under that substance. So the HPMC is placed on the capsule so that it's well coated and it's very easy to perform a rexes. I also use the same MVR blades to make the side port incisions, and these incisions are made deliberately small so that they don't cause any wound leak. Especially the chopper side port incision is made as small as possible so that when you're doing the chopping maneuvers, you're not very uncomfortable. So the same way, I also perform my rexes with a cystotome. So in my second hand, I like to use a curved forceps, which I'll insert into the side port to stabilize the eye and make the capsular rexes. So after you start the rexes flap and fold it over, the mantra here is to keep that flap flat at all times. And I like to keep that folded over flap as a template to follow my rexes. So as you see here, because the flap is kept folded over at all times, it is not bunched up. We get very good control and we're just trying to follow the contour of that folded over flap. So we end up with a nice 5 to 5.5 millimeter circular rexes that is well centered here. So as this is a soft cataract, it's very important that we should have a very decently sized rexes so that it's easy to maneuver the nucleus and pop it out of the bag, because sometimes it's not so easy to chop a soft cataract. The importance of a hydro also cannot be understated here, because in a soft cataract, it's very important to have that nucleus to be mobile. Just go under the flap here, lift up the margin of the rexus, and then just keep injecting until you get a nice wave. So we're using the Veritas phaco machine here for this case. So I also use the same customized pentagon-shaped phaco tip. The advantage of this tip here is because of this larger opening, the holdability is very good and it is sandblasted as well, which also helps in the fallability and the nuclear fragmentation. So we're using a high vacuum setting so we can hold easily and chop a soft cataract. Here you can't use much phaco, so I'm just using mostly vacuum here to get a good hold for the direct chop, holding it only vacuum in a very vertical angle, and this chopper can now be used to meet the phaco tip and get a nice chop right out the middle. So this is made possible in a soft cataract because of the high vacuum setting. And this custom phaco tip, because of the large bore opening, it gives very good holdability. So even in a soft case like this, you can still manage to chop these cataracts quite well. So here we're just trying to do more chops and make smaller nuclear fragments, which then can then be easily removed and emulsified in the center. So sometimes it's a little difficult to get a good hold in a soft cataract like this. So the idea is to just keep making smaller and smaller fragments. And once the endonucleus is out, probably the epinucleus shell will just pop out very easily. So again, here we're trying to do another chop, but sometimes the nucleus just eats up because of the soft nature. If you can't get a chop in one segment, it's okay. You can just rotate the nucleus again, do a chop in another segment. So again, holding in the dense part with high vacuum, and then we can get a chop here and holding again. And now this nucleus is free. So once you've got one piece out, the rest of it will come out quite easily. So we're just using mostly vacuum, barely any phaco. And then we can rotate the rest of the nucleus, and using the high vacuum setting, the rest of the nucleus should also be able to emulsify easily. So you can just see the stability here, even though I'm using a vacuum of around 550, a flow rate of 50, the chamber is absolutely stable. So that speaks to the fluidics of the machine. And also, once your incisions are well made, you will find there's no leak in the chamber and the case can be completed very easily here. So that will be the phaco part of it. So now switching to INA. So for INA, I use a vacuum of 650. We use specialized tips for the IA segment. I like to use a hybrid tip. These tips are very safe because sometimes when you want to polish the posterior capsule, and in case you grab the posterior capsule, they have a much lesser chance of causing any damage. So this is the customized hybrid tip that we use usually. I prefer to do coaxial. I always like the fluidics that come in the coaxial. I personally don't use bimanual so much because I feel the chamber is not as stable as a coaxial. And because the placement of the bore opening is at the apex of the IA tip, you can see the cortex is grabbed very easily. There's hardly any effort here. So because the high vacuum setting and the placement of the opening is at the apex, you don't really have to struggle too much to get hold of even the subincisional cortex. As you can see, it's very easy to finish the INA in just a jiffy. So now we can easily polish the posterior capsule as well. And that's the end of the phaco part. We're now preparing to inject the lens in. I'll just show you the injector. The POC comes in preloaded form. This is a non-toric version. So just like our other preloaded J&J IOLs, this also comes in the same injector. You just have to inject some visco into the openings. And then we can prepare to place the lens in. So the advantage of a preloaded system is that always you know that there's not going to be any issue with the haptics being stuck in the plunger, and it always gives you a lot of peace of mind when using the preloaded systems. So let's fast forward to the injection here. So this usually goes through 2.4 or 2.8. I personally use 2.8 incisions for most of my cases. So we're just injecting it straight into the capsular bag. And as you can see here, the POC does not have any rings. It's a purely refractive IOL. So the way this has been designed is that just like the IHANS, it's got negative spherical aberration and it's got a central steepened zone. So this gives that EDOF-like effect. So that the patients have good range of vision after the surgery. what we've seen is the spherical aberration that is there in this lens is about 0.5 to 0.6. So we measured this using the eye trace, so it's a little more than the eye hands, which is why explains why patients see a little better near vision in comparison to the eye hands eye work. So we've been using this very routinely now for the past year or so, and we've got very good results, especially in the tricky cases like the post-refractive cases in which we don't want to place any diffractive IOLs. This could also be a great option. So that's pretty much almost the end of my case. So we're just removing all the visco now, and we'll be hydrating the incisions and finishing up. So thank you for your attention. That's the end of the surgery.
Excellent surgery.
Yeah.
So thank you for doing again such a beautiful surgery, which was so effortless. Today's all the three surgeries were like, like water flowing. So it looks as though there's nothing much to cataract surgery and to IOLs. So, Gaurav, your experience on toric ODC you've implanted, or Dr. Suresh Pandey, or
Yes, I have
Ayush?
implanted quite a few of the Odyssey torics also. But the good part is that the tolerance of the Odyssey to a small astigmatism is pretty good. Like if you have a plus minus half, as compared to other trifocals like even the Synergy or the Panoptics or the others, they are very sensitive to even small astigmatism. So if my threshold for correcting astigmatism would be almost like 0.25 or zero point 0.5 when I'm doing most of the other lenses, the Odyssey, you still have that small scope that I would not say that I would not correct astigmatism, but if you go off by half a diopter, it doesn't compromise the vision too much. So that's one good thing about the Odyssey over the other trifocals available.
Aditya,
I have implant here. Go ahead.
Aditya, my
Yeah, yeah.
question to you for planning micro monovision patient in myope and micro monovision in hyperope, what is your cutoff line or what is your planning?
Okay,
What is,
so it's like this. The thing is, my understanding of doing this monovision has improved a lot after I started to perform Press Beyond, because Press Beyond is also sort of like monovision, but it uses spherical aberration to get better depth of field. So what we do is when we are planning a pure C case, so what we've noticed, pure C has a negative spherical aberration of about minus 0.5. Post-op, you need negative spherical aberration between 0.3 to 0.6 to get the depth of field, right? So in patients who have, let's say, a very low positive cornea, let's say they have something about minus 0.1 or 0.2 spherical aberration of the cornea, then you implant the pure CN and then you just put plano on both eyes. They will end up getting very good vision without the monovision planning at all. But in patients who've got more positive spherical aberration, let's say they have like 0.3 or 0.4, if you implant the POC, you're not going to get the therapeutic range. So in those patients, you can aim for a micro monovision, like a minus 1 or 1.25, so they get a better near vision. So I don't go by whether it's just plain myopia or hyperopia. If you have an aberrometer that can measure the corneal spherical aberration, you can plan your cases accordingly. So that is what we.
do you feel sometime in a low ACD you have to plan a little more of hyperope because these patients end up in more myopia? See, my planning for moderate to high hyperope is to make them first eye lowest hyperope and see the result after 10 days and then plan the other eye according to the result. Do you
Okay.
feel ACD has some role in planning hyperope, especially the moderate and high hyperopes?
Yeah, it can see, but the thing is, all our cases are by default put on IOL master Barrett through Toric. So with that, whether it is high eye probe or whether it's shallow chamber, we are still able to get good results because of the optical biometry and the latest formula. But my experience is it's mostly to do with the amount of spherical aberration that you need post-op. So if you're able to target that range of spherical aberration.
Doctors as well. And some of the doctors who are physician, they were very happy with the technical Odyssey lens because they didn't want to, they want minimum dependence on glasses. So this lens is wonderful lens, and this gives very good results. And of course, the proper counseling is important and proper workup is important. And once you explain them properly, especially those cases who really don't want, who minimize dependence on near glasses, this is a good choice. Technical ODC lens.
Okay, I think, Gaurav, we've discussed almost all the points and
Namrata, can I add something?
yes,
Patient
yes.
with like post refractive surgery. Gaurav, you will put pure C in hyperopic treatment done earlier, or there is any difference in your planning in hyperopic LASIK done in the past or myopic LASIK done in the
So,
past?
yes, sir. So post-hyperopic is, of course, more tricky than the post-myopic always, because post-hyperopic, the cornea is already a little hyperprolate kind of a cornea, and it already has a very high negative Q value. And typically, I would go with something which is like neutral sphericity, or like one of those lenses which are not having any specific, because also hyperopes, they tend to have more complex optics. I mean, they're less tolerant to any kind of decentrations and aberrations as compared to the myopes. Now, in a myope, I would definitely have used both the Pure C and even one Odyssey, where the patient was insistent that he just does not want to wear any glasses. And he had just had a correction of about -3 or 4 diopters about 10 years back. And now one eye had gone to become -8 with the lenticular myopia. And he was just not going to wear glasses. So we lift out all the corneal aberrations, did the eye trace, and did the centration of the ablation, and everything was looking good. And we did have his historical data and everything. So we could actually do a very good biometry and come pretty close to emetropia. And we achieved emetropia in that patient, and patient has done extremely well. It was a bit of a concern for me that using a lens which is like this. But otherwise, in a hyperopic, I would probably not go in for one of these lenses, post hyperopic LASIK. But myopic LASIK, I do have a few patients with both the Pure C and one with the Odyssey, and a couple of them even before with the Synergy, who have done quite well. But it has to be very, very well kind of researched before you plan to do that.
Actually, I'll share one patient where the hyperopic LASIK was done. One eye we did the eye hands, and after seeing his comfort zone, then we were more aggressive in putting the pure C in another eye, and he's doing well. Myope, there
Should
is
work well.
not much.
Should
It
work
also
well.
depends on the amount of hyperopia that was corrected, sir. If it's like a low hyperop, it's okay. But if it was like a +3 or a +4 high hyperopia, then these lenses might not have been a great option.
So in
Also, the angle
hyperopic,
kappa,
post-hyperopic classic never put a Vivity.
Vivity, of course, my God. Yes, you're right.
Yes.
Never put a Vivity, because then, it becomes a celebrity case. Okay, any other comment anybody would want to say? I think we've had a great discussion. Like I said, the surgeries were absolutely flawless, and the points that came out of discussion were really very good. Like I said, I don't know what is the future of Synergy. Maybe J&J can tell us if they are on their way out from India also. But I know for sure that in the West, they are no longer there.
Odyssey is a better lens, no doubt.
Having said this, I liked Synergy also. It was not a bad lens. It was a
For
good.
great near vision, actually, Synergy may be
Yeah.
slightly better than the Odyssey.
Okay, so with this, I think we close, and our live Surginars have always had a audience which has been much more than normal webinars, mainly because they are deferred life surgeries, and also because of the fact that there's a lot of discussion which is there. I would request J&J to maybe in the next Surginar have cases other than normal cataracts, and then because that generates a different interest which we've not had till now. We would like to thank all our surgeons who've taken time out to showcase their cases, the panelists for sparing their Wednesday evening 4:30 to 5:30 from their busy schedules. Also would like to thank the audiovisual team of Johnson & Johnson. I think it is Swarnim, and they do a great job always. Would like to thank Mr. Sami from Johnson & Johnson, and would like to remember Mr. Jaswinder, who introduced Surginar to All India Ophthalmological Society. And thank you so much, and hope to see you on another platform. I think we have another couple of Surginars again planned. So Mr. Sami will help in that. Thank you, Sami. And like I said, we'll try and get beyond normal cataracts, some other
Yes.
cases also with J&J. Thank you. Thank you so much.
Thanks, Dr. Namrata.
Thanks,
Thanks.
Sarji. Thank you
Thank
so
you.
much.
Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you.